Hi, I am going to share some information about COVID-19 pandemic. This is a time Australian authorities and especially Victorian authorities are getting ready for COVID-19 pandemic. I am going to use a couple of resources from internet to discuss how to prepare the hospitals or healthcare workers in communities to face COVID-19 pandemic. This is depend on the two publications. One is Handbook of COVID-19 Prevention and Treatment, which was released by Chinese authorities very recently. And the second one is the Pandemic Plan for the Victorian Health Sector, version 1, released on 10th March 2020. I want to emphasize that information and guidelines and knowledge about COVID-19 is changing rapidly. So please follow the relevant state or federal government guidelines or protocols in taking decisions. However, sharing knowledge from Chinese experience is very important at this moment because we don't know much about this pandemic or we don't have experience about mass scale infected COVID-19 patients yet. Hopefully, we can tackle this problem successfully if we get ready in on time. Pandemic plan for the Victorian health sector divide this plan into four stages, stage 1 to 4. Now we are in the initial containment stage. What does it mean? It means that monitor and investigate outbreaks as they occur, identify and share accurate information about the virus on a timely basis, contribute to local and international research effort if possible, communicate with the community about the nature of COVID-19, communicate with at-risk groups, and prepare hospital surge management activities to be ready for potential increased demand, and engage closely with the primary care sector to ensure appropriate clinical knowledge, response, and capacity. Out of this, my main aim of this presentation is to prepare hospital surge management activities to be ready for potential increased demands. This is my own presentation reflecting from these two resources, and I am responsible for what I am discussing today on this presentation. And also, I want to inform or educate community about what this pandemic plan means to the community. Again, I want to emphasize that this is not to cause panic and just for information sharing. On top of the COVID-19 infection, we are reaching the winter in Australia. In July, August months, we do see a lot of influenza or flu season, and COVID-19 pandemic is going to coincide with this period. Therefore, the book or the pandemic plan recommends that annual influenza planning should be integrated to COVID-19 plan. Staff influenza immunization, the promotion of influenza immunization to all at-risk patients are mandatory in this critical period. As I am a pediatrician, I am very concerned about bronchiolitic patients presenting during this winter months on top of the COVID-19. I just got this information from Department of Health website. Even though this information is a couple of decades old, it shows that how the peak of respiratory syncytial virus bronchiolitis in the community presentation in month of July from 1996 to 2000. So this shows only the RSV bronchiolitis or respiratory syncytial viral bronchiolitis which happened during winter months. We know that there are other viruses which cause bronchiolitis and it does not include here. So we are going to face these viral bronchiolitis on top of COVID-19 pandemic. So I'm going to give a brief introduction of this book. This book was done by a group of authors, and editor is Professor Tingbo Liang, who is editor-in-chief of this book, mentioned that sharing and collaboration are the best remedy. I strongly believe in that, and I go by this statement, sharing and collaboration. And also, thank you, China, for giving this enormous information about preparation and experience about China pandemic. And also thank you, Alibaba Jack Ma about helping this book available for all of us throughout the world. And this book has few sections, and part one is a prevention and control management. Again, going back to our local pandemic plan from Victorian government, it says managing acute presentation to general practice and emergency department, where we are going to face mainly emergency department. All health services should have comprehensive triage and risk assessment protocols. This is what I am going to discuss in my next few slides. Acute Acute care providers should plan for mechanisms to segregate patients presenting with acute respiratory tract infection from the remainder of the patient. So this is also I am going to discuss as per Chinese experience. And cohorting of these patients in a separate waiting room may become necessary. So these are the three main important factors highlighted in pandemic plan for the Victorian health sector, which is clearly described in this booklet. What China has done for layout. They have started the fever clinic, or they have given a recommendation depending on their experience for a separate independent fever clinic, which is exclusive one-way passage at the entrance. This makes a sense. And because this is highly infectious, the patient should come in one door or the one entry and exit through another door. If they should not come through the same door as the exit. So knowing this, we have to plan our fever clinic or whatever the clinic or triage area as a one-way entry and one-way exit. They recommend to people movement into 3 zones and 2 passages: contaminated, potentially contaminated, and clean. 2 buffer zones in between these 2 zones. And appropriate standardized procedures for medical personnel for donning and removing the personal protective equipment. In this layout, there should be a place for donning of PPE, which should be supervised by infection control technician or nurse, and also removing the PPE should happen in a separate place, not like going to the theater. And full-length mirrors with flowchart should be arranged in this layout to see how this PPE is worn by the staff. And infection control nurse to supervise medical personnel removing PPE, and this should happen 24/7 as a very strict protocol in putting and removing PPE, because this is the most important aspect, one of the most important aspect of prevention of cross-contamination. What China has done in zone arrangement. So they recommended to have independent examination room and pathology lab and observation room, and for critically ill patients to have a resuscitation room. Then pre-examination and triage area for preliminary screening, which may happen outside these special clinics. And separate diagnosis and treatment rooms for epidemiological diagnosis and clinical diagnosis. I am going to discuss what these two diagnoses are in my next slide. These are the criteria given by Chinese Handbook on Epidemiological History and Clinical Manifestation. There are 4 epidemiological criteria and 3 clinical manifestations. It is better to know this in detail, and 4 epidemiological history include: within 14 days before the onset of the disease, the patient has a travel or residence history in the high-risk regions or countries. That is what the common practice at the moment is. Within 14 days before the onset of the disease, the patient has history of contact with those infected with COVID-19. Straightforward, they are at high risk. Then within 14 days before the onset of the disease, the patient had direct contact with patients with fever or respiratory symptom in high-risk region or countries. So in my opinion, criterion 1 and 3 overlap each other. Number 4 is disease clustering. 2 or more cases with fever and or respiratory symptoms occur at such places as home, offices, school, classrooms, exam, etc. within 2 weeks. Now this is, in my opinion, this is going to be really challenging in winter months, because we know by experience in winter months, bronchiolitic patients, especially pediatrics, who come to the ED or our practice, says there are brothers and sisters and daycare are sick with fever and cough. So this is a epidemiological history diagnostic criteria. When it comes to clinical manifestations, the patient has fever and respiratory symptoms, the one criteria. Then the second is the patient shows CT findings of COVID-19. And third one is pathological diagnosis or pathological finding of normal or decreased white cells or lymphopenia. How we are going to come to a diagnosis? If there is one epidemiological history and two clinical manifestations, there is a suspected case diagnosis is yes. If the patient has no epidemiological and meet three clinical manifestations, suspected case diagnosis is again yes. But if there are one or two clinical manifestations, we need to have expert consultation. This will be a huge challenge for us to diagnose or isolate patients. Depending on the Chinese experience, we need to have our own criteria of diagnosing or triaging these patients in Australia or in Victoria. The zone arrangement of these patients looks very straightforward. With epidemiological history and fever and respiratory symptoms, they will go to COVID-19 zone. Patient with, they call it a regular fever, with no epidemiological history, they go to the regular fever zone. This looks very simple, straightforward triaging. However, my opinion or my question, now we are going to end up in regular fever zone. Usual bronchiolitis in winter months that we get quite large number of children end up in a regular fever zone may end up in COVID-19 because of the time delay in diagnosing. So we have to find the way of tackling these patients. Then very importantly, we have to arrange the workflow management. This is the best time to organize or get ready for the workflow management. Fever clinic and isolation ward staff, strict training and supervision of PPE doing and removing. The staff should be divided into teams, and maximum hours of work is 4 hours in isolation zone. Disinfection of whole team as a group, which make easier for disinfection. Before going off duty, staff must wash themselves or have a shower or bath. Now, I believe we need to have a supervision people for PPE trained separately for this purpose. Workflow management. Frontline staff in isolation area shall live in isolated accommodation. This may be challenging. We need to find out, this is what the handbook recommends, but we need to find out how we can give isolated accommodation for frontline staff. And they should receive a nutritious diet for them to keep their immunity at optimum. Then we need to monitor and record their health. If they are symptomatic, we need to follow the protocol. When staff return into normal life, again, it's a tedious process of testing them. If negative, they should be isolated for another 14 days collectively. So this gives us some idea about how we should plan our workflow management during this pandemic period. Patient management. Patient with fevers should wear masks. However, in children, pediatric age group, I doubt about how we are going to wear masks for infants and younger children. We need to find a better way of doing these things. Only patient should allow to enter waiting area, and in pediatrics we should allow at least one parent to enter, and minimize or stop patient visits. And again, in my opinion, we have to have some neonatal and maternity services management protocol separately. Personal protection for the staff. The handbook categorizes personal protection to 3 levels: level 1, level 2, and level 3. Level 1 is the basic protection method for pre-examination triage and general outpatient department or the most of the hospital staff, with disposable surgical cap, disposable surgical mask, work uniform, disposable latex gloves, and or disposable isolation clothing if necessary. Now, work uniform, most of the time nurses wear their own uniform, but doctors and some other healthcare workers use their own clothes. I believe during this period we all should wear a scrub I'm going to discuss it in my later slide. Level 2 protection is the fever outpatient department, isolation ward area, non-respiratory specimen examination, imaging examination of suspected or confirmed patients, and cleaning of surgical instruments used with suspected confirmed patients. They should wear disposable surgical mask, medical protective mask N95, work uniform, disposable medical protective uniform, and disposable latex gloves and goggles. Level 3 is the most top of the range of this protection, and it comes to all the proceduralists like tracheal intubation, bronchoscopy, gastroscopy, and surgical staff, disposable surgical cap, N95 mask, work uniform, disposable medical protective uniform, latex gloves, disposable, and full face respiratory protective device or powered air purifying respirator. So this is a very top level of protection for high risk staff. This handbook gives a very clear picture of how to put personal protective equipment, and we should follow these steps, and someone should thoroughly supervise the steps. Is also stepwise approach, and this should be also important, very important, as putting the gear on, because if your opinion depending on after reading this, we need to train. Okay, so I'm going to end my presentation for 20 minutes, that sharing and collaboration are the best remedy, as this author of this book mentioned. We have only way to get out of this infection, and thank you for your patience. I'm going to do a diagnosis and treatment from these manuals in near future. Thank you for your patience.